I'm Kushmita, Assistant Professor from School of Physiotherapy from Sri Balaji Vidyapith. Today I will be discussing an important topic, bronchial asthma. In this session, we will look into what is asthma, its prevalence, types of asthma, its pathogenesis, pathology, clinical feature, its investigation and management. By the end of this class, you should be able to understand the mechanism behind the asthma and its management. Let's begin the session. So let's start with the simple question, what is asthma? The word asthma actually originates from the Greek word, it means short of breath. Asthma is a clinical syndrome that occurs in all people of all age group, though it commonly begins in the childhood. It is a chronic inflammatory disease of airway characterized by recurrent episodes or attacks of wheezing and breathlessness, chest tightness and coughing. These episodes often varies in intensity and frequency, and they are usually reversible either spontaneously with the treatment. In simple terms, asthma makes the airways in our lung become narrow and inflamed, leading to the difficulty in breathing. Let's now move on to the prevalence and causes of asthma. Asthma is a condition that occurs at any age, but it is most commonly seen in the children, especially among boys, with a male and female ratio of 3 to 2. Interestingly, around half of asthma cases develop before the age of 10 years, showing that it quite often starts in early life. On global scale, asthma affects an estimated amount of 300 million people of all the age group, making it one of the um, global burden worldwide. Now, let's move on to what actually it happens inside the lungs. Asthma is usually characterized by hyperactive airways, meaning the bronchial tubes are overly sensitive to the different triggers such as allergens, cold air, exercise and infection. When exposed to these stimuli, the air responds with widespread inflammation and narrowing, and this process is called bronchoconstriction. Fortunately, this air narrowing is often reversible either spontaneously or with appropriate treatment. This reversible nature is one of the key features that help us distinguish asthma from other chronic lung diseases.
Let's now discuss about the type of asthma. Asthma can be classified into several ways depending on its causes, trigger, or clinical pattern. But broadly, it can be divided into two main types. One is extrinsic or allergic asthma. Another one is intrinsic asthma. First of all, we can discuss about the extrinsic asthma. This type is usually seen in children and young adults. It is usually linked with the family history, and it's also linked with the other atopic conditions like allergic rhinitis or eczema. It is usually triggered by external allergens such as dust, pollen, almond, dander, or certain foods. In this type, the body's immune system overreacts to allergens, leading to Ig-mediated inflammation of airways. Whereas in intrinsic asthma, this type usually develops later in life, typically after the age of 30. It is not caused by allergens, but rather by a non-human trigger factors such as respiratory infection. It may be exercise, cold air, or emotional stress, or exposure to irritants like smoke or strong odors. These patients usually have negative allergy test, and there is no family history of atopy. Apart from these two main type, we can also discuss about a special type of asthma, which includes your exercise induced asthma, usually triggered by the physical activity. Next, we can discuss about occupational asthma, which is caused by the workplace irritants like chemicals or dust. And another one is drug-induced asthma. Some people are sensitive to medications such as aspirin or beta blockers, which may induce asthma. So, in summary, asthma have different trigger patterns, and the underlying feature remains the same, but reversible airway obstruction due to inflammation and hyperreactivity. Now let's look how asthma actually develops. In allergic or extrinsic asthma, the attack is triggered by the allergens such as dust, pollens, or animal dander. When these allergens enter the airways, They act as an antigen and react with antibody, specifically IgE. Uh, these IgE attach to the mast cell in bronchial lining. This causes an antibody antigen reaction that causes a mast cell to degranulate, meaning they will release several chemical media such as histamine, leukotrienes, and prostaglandins. These substances leads to the contraction of bronchial smooth muscles to bronchoconstrict, thereby increasing the mucus secretion and causes swelling in the airway wall due to the inflammation. This combined effect causes a narrowing of airway, which makes a patient to make a breathing difficult, which causes wheeze and coughing, which are the hallmark features of asthma attack. So, to summarize, the antigen antibody reaction on mast cell triggers a cascade of inflammatory changes that results in the bronchoconstriction and airflow limitation. Let's let's discuss what actually happened inside the lungs during the asthma attack. There are three major pathological changes that takes place in airways. First one is spasm of smooth muscles in bronchial walls, which leads to bronchoconstriction, which means your air passage will become narrower, making it difficult for the patient to breathe, which the air in and out of the lungs will be difficult. Second one is edema of mucous membrane of bronchi and bronchioles. The lining of bronchi and bronchioles becomes inflamed and swollen, further reducing the diameter of airways. Third, excessive mucus production and mucus plugging. The glands in airway cell wall produce a thick, sticky mucus which can block or plug the airway completely in severe cases. So, during the asthma attack, the patient trying to breathe through the airways that are narrowed by the muscle spasm, swollen by edema, and obstructed by mucus. These three changes together cause the airflow limitation, leading to wheezing, shortness of breath, coughing, and characteristic of tightness in the chest. The pathological changes that we have discussed in the previous slide, the bronchospasm, mucosal edema, and mucosal plugging together lead to the airway obstruction. As a result, air cannot flow freely through the bronchi and bronchioles, which explains the difficulty in breathing, wheezing, and prolonged expiration that we see during the asthma attack. And it causes prolonged expiration that we can see during the asthma attack. On microscopic level, the bronchial walls became infiltrated with the inflammatory cells, particularly eosinophils, which can play a major role in maintaining the airway inflammation. Over a time, there will be thickening in the epithelial basement membrane, a key histological feature of asthma. However, at the end of the attack, these changes will be completely reversible, especially with the prompt assessment and treatment. However, if the asthma occur repeatedly, this condition remains poorly controlled. The airways undergo long-standing structural changes, which causes the airway remodeling, which includes hypertrophy of the smooth muscles of bronchial vessels, and it causes permanent thickening of mucous membrane, which can increase the number of globular cells and mucous gland, and it also causes distension of alveoli due to air trapping, which leads to atelectasis of alveoli and becomes blocked with the mucus plug. Now let's discuss about the common clinical features which the patient will be experiencing. The main clinical feature of asthma are quite characteristic. Patient often experience a recurrent episodes of wheeze, whistling sound during breathing, cough, breathlessness, and chest tightness. These symptoms often occur at a night or early morning. These may vary in intensity from mild to severe cases. When the attacks become continuous or severe, the condition may progress to serious state called status asthmatis, which is a medical emergency requiring immediate treatment. Let's discuss about separate symptoms. Wheeze, wheeze. Wheeze is a highly pitched whistling sound usually heard during the expiration, but in severe asthma it can also be heard during the inspiration. Dyspnea or shortness of breath is often intense occurs during the inspiration expiration because the air gets trapped in the lungs. And next we can move on to cough. Cough at the beginning of the attack, the cough is dry, unproductive, and barking in nature. This can worsen the bronchospasm and breathlessness. As the attack subsides, the cough becomes productive, thick, and tenacious sputum sometimes forms caused and mucus plug. Next we can see about the chest tightness. Patients commonly describe the feeling of heaviness and tightness in the chest, especially during the attacks. Breathlessness episodes. Some patients might experience this breathlessness episodically worse at night, which can be triggered by allergens and exercise, cold air, or stress. To diagnose and monitor asthma, we use combination of clinical examination and investigation to conclude asthma. First one, we can discuss about the pulmonary function test. Spirometry is a gold standard method to investigate the bronchial asthma. During asthma attack, FE1 ratio will be reduced. Forced expiratory ratio will once again will be reduced, usually less than 80 percentage of value, and FE1 to forced vital capacity ratio also drop down, and peak expiratory force is also reduced and show variability with the symptoms. Improvement of V1 second by more than 12 percentage and 2 ml after bronchodilator confirms a reversible airway obstruction, that is a hallmark of asthma. Next we can discuss about the chest radiography. Often it used to be normal, but it shows hyperinflammation during the severe attacks. It also helps in excluding the other lung diseases. Then we can move on to the full blood count eosinophil. Eosinophil on full blood count suggests allergic inflammation, and serum IgE or allergen specific IgE may be elevated in atopic asthma. Sometimes the sputum examination reveals eosinophil, charcoal, Lenant crystal, and in a clinical examination, breath sounds are vesicular with a prolonged expiration. Wheeze is usually highly pitched and mostly expiratory, sometimes inspiratory in severe cases. Together, this investigation help confirm the diagnosis and assess the severity and guide for the management. Next, we can discuss about the management of asthma. Asthma management has three main goals: to relieve the acute symptoms, prevent future attacks, control underlying inflammation. First of all, we can discuss about the relievers which give acute relief from your symptoms. Short-acting beta antagonist, which includes salbutamol, terbutaline, phenol, which can causes rapid relief of your symptoms, wheeze and breathlessness. Next reliever is short-acting anticholinergics. Ipratropium bromide can be used for acute exacerbation, especially if beta antagonists are insufficient. Oxygen therapy can be is indicated for patients with severe hypoxia. Antihistamines or epinephrine may help when allergy contributes to symptoms. Next, we can see about the preventive or prophylactic therapy, which are indicated for controllers. Master cell stabilizers like sodium chromoglycan prevents allergen-induced attack, especially in mild asthma. Inhaled corticosteroids like beclomethasone and metamethasone is indicated if the exacerbation is lost for more than 2 years, and using a short acting beta antagonist for more than 3 times per week, or symptoms even continues after 3 times a week. This helps in reducing the airway inflammation and prevent the remodeling. And keynotes which can be followed to give patient education is to avoid triggers whenever possible. Patient education is essential for inhaler technique, address recognizing the warning signs. Treatment should be tailored according to the severity responses, and the step up and down is needed for the treatment. Thank you.